Good evening, everyone. We welcome all the delegates for the second series of module conducted by the SIG research methodology under the aegis of IFS. We have introduced these web series basically to help you understand simple concepts. These are simple bite-sized concepts for you to apply in your daily practice, be it writing a research paper or if you want to interpret or critically review articles in journals. So to begin with this journey, I would like to go on to first session, and to start the session, I would like to call upon the moderator for the session, Dr. Ruma Satvik, who is a senior consultant and professor of reproductive medicine at Sir Gangaram Hospital, New Delhi. To you, Ruma, to conduct the session.
Thank you. If you can move the slide.
Yeah, I'll do that.
Thank you all for being here. And we're going to be talking about the first talk is an important one. And it's going to help you grasp the concepts of sensitivity, specificity, and positive predictive value and negative predictive value that we come across. Also through use of examples as to where you can use them in your everyday practice. Now, you all know Professor Dr. Mohan S. Kamath. He is the professor and head of reproductive medicine and surgery at CMC Bangalore, but also holds a master's in clinical trials from University College London in 2023. You know him as the person who does many Cochrane reviews, but he's also the editor-in-chief of Journal of Human Reproductive Sciences and has helped several students through their journey in fellowships and now MCH courses, which he now conducts at CMC Bangalore. You know all about his publications. We're not going to go there. Over to you, Dr. Mohan.
Thanks, Ruma. Thanks, the IFS and everybody here. I think I'll just go away, start with sharing my slides because somebody has to give me allowance. Okay.
Yeah, I think you can, sir.
Yeah, okay. Is the slide visible? Yeah.
Yes.
So I'll just go straight to the talk because of time constraints. So I must add here that I'm not a specialist on this particular topic. This is something that we have just gained experience over the last few years. This is not something easy to understand, but that's why I'm going to go slow and share our own experience as a clinician that where you can probably use this information. And if there are some queries, if I can respond to that straight away, it's fine. But if I'm not able to, I'll definitely get back to you through email. So feel free to connect. So diagnostic test accuracy, this particular talk, I'm just focusing on few terms. We are not going to go heavy on the terms. I'm just looking at sensitivity, specificity, positive predictive value and negative predictive value and a bit of likelihood ratio, but I'll not go beyond that. Also probably sensitize the audience on why do we need to know this, especially as clinicians. And I'll probably take you through one example of one of our studies, which was quite a learning experience for all of us in our department as well, and how these simple studies can have such a big impact. So that's what it is. Diagnostic test is as simple as that. It's used to confirm or identify a disease condition. So now this is a textbook definition. Should be quick, safe, accessible, non-invasive. It's an ideal world, but that's where it is. Now the term that I would like to highlight here is there are two aspects. Like whenever we are talking about diagnostic test, and if you're looking at a study, try to look at what is the gold standard or the reference standard. That is the one which is considered the best in terms of identifying a condition. And then when we are talking about a new intervention, a new diagnostic test, that's the index test. So these are the two terms we need to keep in mind when we are looking at a diagnostic test accuracy study. So now I'll give you an example of this. So if you're looking at tubal evaluation, laparoscopy generally would, by consensus or otherwise, would be the gold standard or the reference standard. Similarly, if you go by the book, many times serum progesterone, mid-luteal progesterone is taken as the gold standard or a reference standard for documenting ovulation. Prenatal, of course, now there are a huge number of genetic platforms, but then karyotype at some point was the gold standard, but of course things have moved on. So I put a query there. So that this particular talk, I'm basically touching on the first four, the ones in red font, and I would touch on likelihood ratio because ultimately all these things connect to likelihood ratio and how it can help us. Now, this is my attempt at drawing and it isn't great, but then I just want to highlight here that try to imagine that what we are doing when we do a test, we are actually trying to identify those with the disease and those without the disease. So the red peak here is the disease, the population which has got the condition, and the yellow peak here is, of course, the ones who don't have the disease. So every time in the OPD or the in your ward or wherever in the clinical situation, you will have a test which needs to identify those with the disease or rule out those who don't have the disease. So the test cutoff, this is an ideal world where you do a test and those who are positive are the ones with disease and those who are not positive are the ones who are free of disease. But in the real world, this doesn't happen. So this is a little crowded diagram, but I'll just spend some time. So you can see the red and the yellow peak are actually overlapping. This is what happens in real world. So let's look at A, B, C, or I'll just take A and C here. Now, if you have a test which is having a cutoff at A, so let's say you're taking sugars. So we use this sugar example as, let's say 100 milligrams sugar random, and anything above that is diabetes and below that is non-diabetic. So if you look at, if I have a cutoff at 100, you can see here that the red peak is totally above 100. That means that essentially it's identifying, once you have a cutoff of 100, it's identifying almost all the patients with the condition. So this test, if you keep a cutoff at 100, that is at A, it is 100% sensitive. Okay. But it will also identify a few more and brand them as having disease, the ones who don't have a disease. So, but let's leave that apart. And just the concept is about sensitivity and specificity. Now, if you have a cutoff at, let's say C, which is higher, let's say 140 milligrams percentage, then you would probably, if it's negative, the whole of yellow peak is behind it. That means that you have correctly identified all those who don't have a disease. And this is 100% specific. But of course, then you also miss out a lot more of those who have the disease. You can see that a part of the red peak is behind that cutoff. So it's always a trade-off when you look at this. You can't have best of both. That is something that we need to remember. And this is a diagram just to convey how cutoffs can change the sensitivity and specificity, and we need to really decide this, especially in continuous variables. That is, you have a number game. Yes or no is a dichotomous outcome. So I'm just going to go on highlighting this particular thing, concepts again and again in different ways, and give clinical example. So sensitivity again is proportion of people with disease who have the positive disease, the positive test. Now this is the statistical way of saying it, but let's come back to our own fertility specialty. And the way to look at it is, let's say you have 100 women with complete tubal block. If you do an HSG and 60 of the women are actually picked up by this HSG, that is that out of those 100 women, only 60 were picked up by HSG as bilateral block, then the sensitivity of that test, in this case, it's HSG, it's 60%. That means it's only picked up 60 out of those 100 women with complete tubal block. That's how we go for sensitivity. Now, coming to specificity, it's proportion of people without the disease who test negative. That's the way we express it in statistics. But if I give you an example here, 100 people without COVID in a room, you do a COVID test and 90 of them actually don't have the disease. That's negative. Sorry, COVID test is negative for them. That means that COVID test of that particular COVID test has a specificity of 90%. I hope you're with me here. It's a concept that we need to understand. Specificity is all about trying to pick up those who do not have a disease. Sensitivity is all about trying to pick up those who have the disease. Okay, so this is something that we should be familiar with. Slightly different concept, PPV, it runs the other way. The fundamental difference between these two terms, that is sensitivity, specificity, PPV and NPV, is try to imagine that the test is done. That's the fundamental thing, I would say, a take-home message. Proportion of positive tests, which are true positives. That's the statistical way of putting it. But if I tell you, for a PPV of 80% for TB test, let me put it easy in an easier way. So let's say if a PPV for a TB test is 80%, that means that 100 women who tested positive with that TB test, actually 80 had the disease. I hope this is the reverse of what we were doing for sensitivity specificity. Here, the test is done. We need to know the PPV of that test, because then only you can tell with certain amount of certainty that, okay, this person has that condition. I'm going again on this. If the TB test has an 80% PPV, it essentially means that out of 100 positive tests, 80 will have the condition. If PPV is, let's say, 15%, that means once the test is done and you have a positive result in your hand, it's 1 in 6 or 1 in 7 only that that condition is there in that woman, you know. So I hope this is clear. I'll just drive home the same thing for negative predictive value. Proportion of negative tests, which are true negatives. The other way is that if the negative predictive value is 99%, that means that if 100 people tested negative, 99 did not have COVID, you know. So if you did the COVID test and it was negative and the NPV calculated whatever the data suggested was 99%, that means that 99 did not have COVID. And this is a very useful information for clinicians when you're actually or trying to counsel patients when we go by this. So these are the 4 terms. And if you want to, I think, put it another way, this is a must-know 2x2 table. Without this, it's very difficult to move forward in DTA. So once we know about this DTA 2x2 table, things get a lot more easier, because you can just move it around and get all the information, because these 4 terms will link you with the next terms, that is likelihood ratio, be it the ROC and everything else that comes around. So again, if you're looking at a 2x2 table, you can see that the reference tests are usually at the top, okay? And the index test is down, and then you actually need to put those, fill in those figures A, B, C, D, and you'll get those, all those terms. So now if you put it the other way, sensitivity is about ability of test to detect all those who have a disease. Specificity is about ability of those who don't have the disease. So always when you think about sensitivity, think about you're trying to pick up those with the disease. When you're talking about specificity, you're trying to pick up those who do not have the disease. You know, this is again and again, we need to reinforce this. But when you move to PPV and NPV, the concept is the test is done. Now you're not really thinking about sensitivity and specificity. You are sitting with the report, and if it's positive or negative, you need the information of PPV, because now you need to tell the patient, listen, you have a positive test, but what is your actual chance of having the condition that we have tested you for? So that's something that is very important and fundamental. And to me, this was a very key information I thought I wanted to convey. Remember that sensitivity and specificity are independent of prevalence of condition, whereas PPV and NPV are dependent on prevalence of condition. And this is a very important bit because then a PPV value, let's say that you're talking about chlamydial infection, and you are sitting with a report in India, at Delhi or south in Bangalore, it will be different here than when you are looking at the same test positive when you are in UK, because the prevalence of that condition would vary. Okay, now I really, we've had few studies done in this part of the world, in fact, in Vellore also, and the prevalence of chlamydia was very, very low in our population. Now that would affect the PPV. So if you have a PPV of 80% in UK, it could, but then remember that it's going to change with the prevalence of the condition. Fundamentally, the final point here I'm trying to drive home is we need to know this prevalence of those conditions. Then only it will help us when we apply PPV and NPV. And that's crucial when we are actually managing our patients. So I have expressed this clearly. I'm just giving an example that when a patient has come to you with an abnormal HSG, so a lot of us are actually in tertiary centers and people will come with abnormal HSG report. At that point, talking about sensitivity and specificity is not exactly going to help. You have a test. All you need to know is the PPV of bilateral block for HSG. Now, if it's, let's say 50%, as far as I remember, that is the PPV for bilateral block for HSG is 50%. That means that 1 in 2, this patient does not have a block. And that means that we actually have to go for a laparoscopy to confirm this. Okay. But if let's say that the PPV was 99% for that HSD for a bilateral block, I would not go for a laparoscopy. Okay. Because there's an abnormal HSG. It is 99 out of 100 telling you the truth. So why should I subject somebody for a laparoscopy? I will explain the second example, which is self-reported history of regular cycle in another, when I talk about the example where we have used these terms, because it is also in some ways a done test. When a patient of ours, a woman comes and tells her cycles are regular, it is also akin to a report with you. There's a test report with you, and how this can be used for diagnostic test, I will explain with an example. So this is the same point. I want this picture to be in your mind. The yellow line is the test results are available. Before that, you can talk about sensitivity, specificity, but once the test results are there with you, if it is positive, you need to know the PPV. If it's negative, you're talking about NPV. Couple of slightly heavy slides. Just bear with me for a couple of minutes. Essentially, you don't really need to know that sentence out there. What you really to know is that positive likelihood ratio is calculated through this formula, sensitivity by 1 minus specificity. Negative likelihood ratio is 1 minus sensitivity by specificity. Now, don't worry, you can always Google and get these things information. But what I'm trying to highlight here is that positive likelihood ratio and negative are calculated again with our basic terms, that is sensitivity and specificity. So those are the 4 fundamental terms that we need to be aware of. Couple of points. If the likelihood ratio, let's say the positive likelihood ratio is 1 or hovering around 1, then that test is actually not useful at all. Okay. And I will take you to the final, a very interesting diagram, which remember that whenever we are doing a test, we have, let's say you start with the baseline that you're suspecting that this patient has a condition. It is called the pre-test odds. That means that what's the probability of this condition? So in your own clinical judgment, you will know that you will think that, okay, this is 80% likely that this person has this condition. After doing the test, it becomes the post-test odds, that is post-test probability. So this is a very interesting concept that I would probably highlight, because it gets linked to this Fagan's diagram or nomogram. And I'm just going to go a little slow here. So let's say if your likelihood ratio was, let's say around 1, and I'm just giving an example. So as I said, this is the pre-test probability. The line on the left is the pre-test probability. So if you say that your likelihood ratio for your test is around 1, that is somewhere here, And before doing that test, the probability of a condition was something in your mind was like, you're almost certain that this person has this issue. You know, it could be a ruptured ectopic. You have every clinical indicator and blood parameters to suggest that she's got an ectopic ruptured, and you're like somewhere like 90% or 95%. If when you join that, this 90% with likelihood ratio of 1 here, and that line will go and hit again 95%. I hope this line is clear. I didn't draw here. If your probability was 90% and the likelihood ratio was 1, when I draw a line through the 1, it goes and hits the post-test somewhere at 93%. And this is where doing that test, because the likelihood ratio was 1, it really did not change the outcome. You know, you were as knowledgeable before the test than after performing the test. And that's something that we need to understand, that it's really not required for us to do tests when certain things are as clear as they can get. So I can give you an example, like somebody with 60 years with history of diabetes and uncontrolled diabetes and all the cardiovascular comorbidities comes with a typical angina pain. You really you are quite sure, like 190% sure that that person has an MI. You really don't wait for those diagnostic tests. You can move on. Giving an example in our context, as I said, if somebody comes with 5 weeks of amenorrhea with some spotting and beta HCG is positive and she's giving telltale signs of hypertension, a urine test is positive, and you do a scan and you see a lot of fluid in the abdomen, doing a beta HCG is not really going to help you, because you're out there, it's 90% or plus that you are suspicion that this is ectopic, and you just go ahead and don't wait for the beta HCG results. That's how it comes down. So this is about pre-test and post-test. So I took you through the journey of sensitivity, specificity. I linked it up with likelihood ratio, because likelihood ratio ultimately gets linked to pre-test and post-test. I will not go further than this. This is the last of the technical, and then I'll go to examples. The final thing is about Kappa's test, or it's about two tests. How are they identifying the same thing? That's what it is about. So we call it agreement. So two tests can be having the same sensitivity, but they might be picking up different set of patients. So this is the final slide, technical. If you have two tests which are showing something like 0.8 kappa, that means that they are almost in agreement. So driving home this point, I just drew this diagram in the afternoon, where let's say you have a test which picks up 3 patients out of 5 with the disease, and your index test also picks at least 2 out of them. You can see that they are identifying the same bit, at least for the 4. The 5th patient, there is slight discrepancy, but this is what agreement is about. I would say 80% agreement, because they are picking up almost the same set. The first one is not having a disease, index also is showing the same. The second one as well, where the third and fourth are having the disease, and they're picking up the same. But the 5th one, the reference is finding out that there's disease, the other one is not. So this is where they are discrepant, but overall 80% agreement that these tests are in agreement. You can imagine a situation where this is the other way around. These are blue, whereas here these are red. Then they might be showing a similar sensitivity, but the agreement would not be there. I hope you're getting this. You could identify out of 10, 5 patients of TB with one test, and the other test identifies also 5 patients, but they are not the ones identified the earlier test. So that's where the agreement can go very different, even though they are of the same sensitivity. We need to remember this. So this is a point. These are all the terms that we talk about when we are interpreting a diagnostic test accuracy study. I'll just take you with the last 5 minutes with our example. So this was some time back, the NICE recommendation. So women with regular cycles, the dilemma, because it came to our mind because we still saw a lot of colleagues of ours performing follicular tracking and documenting follicle rupture, and trying to basically say that ovulation is happening, even in regularly menstruating women. Surprisingly, NICE did recommend mid-luteal progesterone, even stressing that it should be done for regularly menstruating women. Whereas the ASRM wasn't so stuck up with the test. It was like it was keeping you, giving you a little more leeway in terms of whether to perform or not. So we had a question whether we should perform a test of ovulation for eumenoric women, and if yes, when, which test. So the objective of this study, which we launched, DTA, was to estimate prevalence of ovulatory cycles in women who are reporting regular cycles. And we had a single well-timed ultrasound as one of the index tests, and mid-luteal progesterone was the reference test. And we're detecting ovulatory cycle. We are not detecting ovulation. And we wanted to estimate the PPV of self-reported cycle. Now, this is what I was trying to stress, that the test is done. That is, the woman has come to you with a self-reported history. So we really don't have to worry about sensitivity here. We are only talking about a positive test, that is positive predictive value of a self-reported uh, history of regular cycles. These were the inclusion and exclusions. I won't spend time on this. These were our intervention. So we wanted to just say, okay, we'll just do an ultrasound anywhere from day 9 to day 22. We will really not try to document ovulation, but we'll just document anything which suggests an ovulatory cycle. It could be a dominant follicle, or it could be a corpus luteum or a hemorrhagic cyst. That should suffice. And our reference was serum progesterone. And we looked at sensitivity, sensitivity, and all those terms that I've just discussed. Sample size was 208. We found the prevalence of ovulatory cycle. If you take the serum progesterone as a reference test, it was around 88. If you take the one-time ultrasound, the prevalence was 97%. That means that 98 of the women who said that their cycles were regular had actual regular cycles, had ovulatory cycles. And this is the 2x2 table. The last bit that is on the footnote, you are looking at a one-time ultrasound, 100% sensitivity. Specificity was low because there was a phenomena called imperfect reference standard. But importantly, PP was 90%, NPV was 100%. Agreement was almost perfect. You can see the kappa was around 0.8. But the important point here was the PPV. This is what we wanted to tell, was 88 to 98%. And what we concluded was it's a very high prevalence of ovulatory cycles in eumenoric women. You could just rely on the history, really. No need to go to any more testing. And there's perfect agreement between a well-timed ultrasound versus a mid-luteal progesterone. And this study was quoted in the Female Evaluation of Infertile Women Practice Committee guidelines to reinforce the point that we don't really need to do test of ovulation. So a simple diagnostic test accuracy study with the basics that we just discussed was such a valuable study that it actually had an influence on guidelines. Not many of our studies have reached this stage where this study did. So that's why I would probably highlight that DTA is an important area, and it is clinically relevant as well as those who want to do studies. This is one of the areas that not many studies are planned. But as I would say, the principles, just the 4 terms we need to first understand. But I can tell you, it's not easy to interpret. You need to have, those numbers, the PPVs and all on your fingertips. It's not easy at my age. Probably the youngsters probably would keep that. 2x2 table familiarity is very important. Without that, it's not easy. But I would say that join in, start reading DTA studies, and then things would become easier. I'll acknowledge one of my professors who did take sessions for us, and my colleague Chinta Parimala, whose study I have quoted here. I'll stop here. Thank you.
Dr. Mohan, that was excellent as always. And your concept, I mean, the introduction of likelihood ratios to the audience may be a little new. And however you explained it to us with a great deal of clarity using that nomogram. And just to kind of sum it up, you said that for tests that have a high positive likelihood ratio, especially the ones above 90, you don't need a diagnostic test.
Yeah, so it is basically if you are suspecting. So I would just keep the medical legal aspects apart, because then you practically have to do tests for everybody, you know. But keeping the medical legal apart and keeping the medical science in mind, if you suspect something very strongly, then you really don't need to wait for those test results, you know. And that's why you need to have those prevalence in mind, but that's not easy. But with the clinical characteristics, if you feel that the pre-test probability is very high, something like 90 plus, it is arbitrary, but it's a clinical judgment. Then trying to do these tests, especially if likelihood ratio, see if you're already hit 90%, likelihood ratio even at 5, it becomes 90, say 95%. That's all a positive. So that's why it becomes a redundant exercise at that point.
And you'd use the concept of likelihood ratios, summing up multiple parameters, like you said, clinical history, maybe one tiny test like a UPT in that example you gave, and ultrasound perhaps. None of these would be diagnostic individually of ectopic pregnancy, but coming together, you know, history and everything, and ultrasound picture, you get.
Yeah, so that example, I felt beta HCG, serum beta HCG would become redundant if I'm talking about beta HCG in that context.
Right, right. There's just one concept for our audience I'd like you to maybe briefly speak on, and that is we come across ROC curves every now and then in certain diagnostic studies. Would you like to tell us why and where would one use them? Because
see,
they all
again, I would struggle now, but I would probably give you what in my mind it is. So essentially, again, ROC curve is fed again by sensitivity and specificity. So it's 1 minus specificity, and then you have a diagonal line. So once you draw that, again, we don't have to really worry about it. You feed the 2 by 2 table and you draw it. And when the line is parallel, almost parallel, or running along the diagonal line that crosses, then the twist is futile. Okay, whereas if it goes on the left hand corner, that is, it's closer to 1, then the test has got, you know, relevance. That's my understanding of things. That's what I remember. Yeah. But I thought it'll become too heavy, so I didn't put ROC curve.
No,
I thought
I would agree with you. Maybe just one tiny point I'll add, that for outcome variables that are continuous, and sort of predictor variables that are continuous, and outcomes you're dealing with are binary. This is where your 2 by 2 table may not work, which is of course standard table. And here you'd want to use the ROC curve in order to estimate the sensitivity and specificity of that test. And if there are any questions from the audience, it'll be nice if you can put it here. But Dr. Garima, if you have any, you could go ahead and ask.
Chat box. I don't think there are any questions in the chat box.
Yeah. So should we then do the quiz for the audience? It's based on the talk that has just been.
I think that would be interesting. We can do the quiz.
So
I need to hide somewhere.
Okay. You could, I think some of the figures are big, so you could use your calculators. Go ahead and do it. But if you flash on your screen, Shivam, aap hai wahan pe? Okay, he's already put the poll out there. You can take as much time. There are 5 questions you have to respond to. And Shivam, आप बता पाएंगे कि ये touch पे है या कैसे है?
Touch पे, ma'am, same that we have done.
Okay. So that's the first question, and it's basically asking you the definition of sensitivity.
How do they mark the answer?
Yeah, I hope Shivam, we tried
by clicking on that, sir. Actually, we are the co-host now. We can't mark.
Okay.
As a participant, they can mark.
Thank you. Thanks.
So should I just scroll up and will that show the second question?
I think they can scroll themselves.
Oh, okay. Right. Would I urge you all to respond to this? More people, I can see some names there that are students.
And one person have submitted.
Actually, that's
Yeah.
submit. Okay.
Only one person have submitted right now.
Okay. Let's wait for 5 responses.
Yeah.
At least they can see the results, no, and submit.
Yeah, I think they can, but if it's been 5 minutes, maybe we could. How long has it been since the poll was administered?
3.25
Okay,
minutes. Yeah.
maybe another 1 minute, and we will just show them the results.
Done.
Participants, we need more enthusiasm from you. None of those questions out there are tough. Okay, no box for one question. What is that?
Ma'am, 5 have submitted right now.
Okay, what does
Yeah.
this question mean? Somebody is saying HIV question. They can't see the box.
Visible on the screen, the box.
Yeah.
6 have submitted, ma'am.
Yeah.
It's 4 minutes. So should we wait for 5 minutes? 8, 7, 8.
Yeah.
8 have submitted.
Excellent.
Yeah.
So, Neeraj, I think you need to open it on a bigger screen or just expand the box. It is there in the quiz. Shivam, you can project the results at 5 minutes. And
Okay, ma'am. It's 10
yeah.
seconds for now.
Yeah, so please project the results in 10 seconds.
9 have submitted.
Yeah.
Hope we can have 10. It's 5 now, ma'am. Should we
Yes,
share the
please.
result, right?
Yes,
Okay,
yes.
ma'am.
Let's do
Okay.
that.
11 right now.
Okay.
So, ma'am, here is the results.
Okay. All right. That's 73% got the first one right, and 3 of 11 got wrong. And the second one is more or less similar. 3 people got the second one on specificity wrong out of 11. In the third question, 99.5%, which is the right answer, and hopefully you all managed to use your calculators. You got it correct. 9 out of 11 got it correct. In the fourth question, which was on how the CT scan machine, which is being used to diagnose subarachnoid hemorrhage in a population, the results depicted below. Okay, what is the specificity and positive predictive value was the question. And 5 out of 11, so those are two calculations you had to make. 5 out of 11 got it correct. Then we have 4 diagnostic tests, and that's pretty much a decent number who got the last one correct. That's 8 out of 11. So, right, excellent. We can now stop the, is there another one? No, all 5. So it's good to know that at least 3/4 of you got the concept. And let's move on to the next talk. And we have to thank Dr. Mohan for that.
Thank you, Dr. Mohan. A very interesting lecture and how actually research can be put to daily practice. That was a very good lesson. And with this, we go on to our next session. Moderate our next session, I would like to call upon, just 1 second. Yeah. Moderate the next session, I would like to call upon Dr. Bindu Bajaj, ma'am. Madam is professor and head of department and also the in charge of IVF Center at VMMC in Safdarjung Hospital, who has several fellowships and training to her credit and several publications. Good evening, ma'am. Please carry on the next session.
So that was a wonderful session that you took, Dr. Kamath, and interesting.
Thank you, ma'am.
Statistics does make us go sometimes go in complete dizzy, you know. And today the talk with the next talk, which is p-value and confidence interval, I feel that this also needs a lot of the two things resemble a lot, and yet there is a difference between the two. Both deal with 95% range. One deals with the range, the other deals with the significance value. And there's something called effect size, which is more represented by the confidence interval. And we have with us Dr. Dharmendra Kumar Yadav, who's he's an assistant professor and acting head in the Department of Statistics and Demography at National Institute of Health and Family Welfare. He's an excellent speaker, and he has lots of publications in various journals, and he has written books also. So he has been awarded with Excellent Presentation Award at Waseda University, Japan, and Best Paper Award at International Conference in USA. So welcome, Dr. Dharmendra here, and we would like your views on p-value and confidence interval. How do we differentiate, and what to use where, and what is the significance of both? Thank you.
Thank you so much, ma'am, and thanks to organizers and IFS team for inviting me and giving this opportunity to interact with all of you. So I'm just sharing my screen. So I hope my screen is visible to all of you.
Yes, it is visible.
Okay, so I'm just the topic that was assigned to me was how you will measure the statistical significance using the confidence interval and p-value, because these are two important aspects for inference purpose, that is confidence interval and p-value. So these were some basic content that I will cover in this particular session, which was assigned to me. So as we all know that in statistics we have two branches. One is descriptive statistics, and another is inferential statistics, right? So descriptive statistics is just like a brief description about the data set, what the data we have. We just analyze it, what the basic nature, like whether it is normal or not, what is the range, what is measure of central tendency, what is the measure of dispersion, skewness, kurtosis. So this is just like a brief description about the data set. We don't have any additional information from that data, right? So and the second part is your testing of inferential statistics, because it is inferential statistics very important, because it give you additional information for the for decision making or for the future purpose. So this the true beauty of statistics lie in this inferential part, right? Just like you for since you all are medical professionals, so if any patient is coming to you, so before giving any prescription to that patient, you just write some diagnosis. What is your BP level, sugar level, temperature level, and other even any comorbidities there. So this is called diagnosis. So in the same way, in statistics also, before applying any particular statistical test on the data set, we just go for the data diagnosis. So this descriptive statistics is a part of data diagnosis. Before applying any statistical test on the data, you must find out the nature of your data. What are the basic conditions or assumptions that data is fulfilling? Because all the statistical tests are based on certain assumptions. If your data is fulfilling those assumptions, then only you can apply those particular tests. So always, before applying any test, you just go for the data diagnosis process. In data diagnosis, you just check the normality assumption, whether data is normal or not. This is the first important rule. Second is outliers are there or not, missing values are there or not, right? So this is called the data diagnosis. On the basis of this data diagnosis report, you just apply the statistical test. So in statistical inference, we have two branches. One is hypothesis testing and estimation. So in estimation, like we have a population parameter. So population parameter is, there are two things. Population parameter is like if it is known, if it is unknown to us. For example, if you want to know the average height of adolescent girls in Delhi, right? So this is our population parameter. About this parameter, our population parameter is average height of adolescent girls in Delhi. So this average height is our parameter, and this parameter may be unknown to us or it may be known to us. If it is unknown to us, this is called this is like if we don't have any idea about the previous information about this parameter, then we estimate it on the basis of some sample. We will estimate it and we go for the estimation process. What is the average height? So if population parameter is not known to us, then we go for the estimation. And in this estimation process, the confidence interval comes into the picture, right? So if it is unknown to us and we are estimating something, then we will take help of the confidence interval. And this confidence interval will tell us that the exact value, your true value of parameter lie in which particular interval, right? So sometimes it can see that the average height of adolescent girls in Delhi lies between 150 to 155 centimeter, right? So this is your confidence interval. So this is the estimation part. But sometimes our population parameter is known to us. Like from previous studies, anybody has 2 or 3 years ago, researcher has studied, surveyed, and say that the average height of adolescent girls in Delhi is 155 centimeter, 154 centimeter. Now, on the basis, in this case, our population parameter, that is average height of adolescent girls, is known to us. Now, we have to verify, this is a case of testing of hypothesis, because here population parameter is known to us. Now, on the basis of your available data, what the data you have, on the basis of that particular data, you have to verify whether this hypothesis is true or not. That's why this is called testing of hypothesis.
I think your slides
Yes,
are
yes, ma'am. I'm just moving.
all right. Yeah.
Okay, so this is the basic difference.
The slide. He was on the first slide only.
Yes, yes. So this is the basic difference between testing of hypothesis and estimation. So in estimation, population parameter is unknown. That is, we don't have any information. And in this case, we will estimate it. And for the estimation purpose, we use the confidence interval, right? To give the real picture, real location of that particular parameter. But in hypothesis, if our population parameter is known to us, we have some prior information on the previous studies, then we will test it. And for this one, we use the p-value. So p-value, like for if we are going to test the hypothesis, that because we are using the sample in testing of hypothesis, we use the sample to make the inference about the population. So there is a difference between the observed value and real value. That is our population parameter is real value and observed value from the sample. So there is always a difference. Now we have to identify that this difference is by some components or by chance or by random error. That's why this is called significant difference. So is there a significant difference between the observed value and the real value of parameter? So it is expressed in the form of p-value, right? So this is the difference between confidence interval and p-value. In estimation, we go for the confidence interval, and in hypothesis, we go for the p-value. Now, this is the basic inference part, how we go for the inference. We take the different samples from the population, and on the basis of those samples, we are making the inference about the whole population. So I will not go into too much detail. Okay, so this is the difference between statistic and parameter. So parameter is something which is associated with our population. Like we just want to know the average height of adolescent girls of Delhi. So this is a parameter because it is whole Delhi adolescent girls population is our parameter. So we will take, there are two cases. Either we take the information from all adolescent girls height. This is called complete enumeration, or we go for take some samples. So, and we will estimate it with the help of those samples. So any observed value drawn from the sample is called a statistic, which is associated with the sample. So this is a sample version of, sampling version of parameter. So what the role of parameter in the population, that is the same role in the sample, that is a statistic. So in estimation, we have point estimation. We can find out the particular point value, where this particular value of mean, proportion, difference of proportions, odd ratio, relative risk, all this comes in a particular point. Either we can provide the exact value of that particular estimate. This is called point estimation, or we can provide the range of that values. And this range is defined by the confidence interval. A confidence interval consists of we have lower confidence interval, upper confidence interval, margin of error. So this is our point estimate. This is the exact value if you are providing the point estimate. This is the lower limit of that particular confidence, and this is the upper confidence limit, right? So this is the margin of error. Like, what is the difference between the exact value of estimate to the confidence limit and upper and lower confidence? This is the difference. Now, as lesser is the margin of error, the better our confidence interval. Now we go for, first we take this estimation part, like confidence interval, and then we'll proceed for the p-values, right? So this confidence interval p-values give no indication. This is the difference between the confidence interval and p-value. So p-value just so that whether there is a significant difference between the observed values or not, real value, but it doesn't show what is the exact magnitude of that particular difference, right? But in confidence interval, it shows the magnitude also. Okay, what is the magnitude of particular difference? Like, confidence interval is a range of values that tries to quantify this uncertainty. For example, 95% confidence interval means that under repeated sampling, 95% of confidence interval would contain the true population parameter. I'm just giving you one example of the confidence interval and confidence level and level of significance, right? Suppose I'm saying that from the previous experiences of the forecasting, weather reporting, I'm just saying that today 95% chances that today rain will happen in Delhi, right? So this 95% is called our confidence level. Okay, it means what we are saying, that is 95% true. But at the same time, there are chances that rain will not happen, and the probability of happening this is 5%. This is not this is the chance, that is 5%. So this is called level of significance, that what I'm saying, it may be wrong. Okay, so this is called level of significance. So the confidence level is 95%, and the level of significance or margin of error or probability of type 1 error, this is called, or alpha, this is called level of significance, that is 5%. So at the same time, 5% level of significance is also that what we are saying, there is some factors in random. This is called the random chance by random chances, right? So what the significant difference is there, that is due to the random error, right? So this is called 5% level of significance. Now, how you will compute the confidence interval? So we need sample statistic, we need confidence level, we need measure of how high the sampling variability is there. So we need these kind of things for calculating the confidence interval. So confidence level may be your 90%. If I'm saying that 90% sure, 95%, 99%, it totally depends upon the researcher's choice and the nature of your experiment, right? So sample statistics may be your mean, sample mean, single proportion, difference of, so anything which is associated with your sample, that is called statistic. Sampling variability is a standard error, right? So this is a very important component, a very important topic, term, that is standard error. So don't confuse about the term standard error and standard deviation. Okay, so because this standard deviation means this is a measure of dispersion, square root of your variance. So this is a measure of dispersion, that how the observations are deviated from the standard value. That is standard deviation. But standard error is associated with the samples. If we are going for the testing of hypothesis, or we are taking the inference purpose, we are taking the samples. Then with particular sample, suppose we have taken the 3 samples from different locations of Delhi. Now, and these 3 maybe they have the real, equal sample size, but they can still provide the different mean. Although because the observations are different, but the sample size is same for 3 samples, different samples. Now we have to check that which particular sample is giving the more precise result for our inference purpose. So for that, this standard error is our criteria. So standard error, we will calculate the variance and standard deviation. So this is sampling variability. This is the sample statistics. Standard error is a measure of sampling variability. We have 3 samples, I have told you in this particular. We have collected 3 samples with the help of simple random sampling and calculate their mean, sample mean. Now we know that the population mean that is given from the previous study, that is 25, like 25 kg or something. Then for different 3 samples, there are 3 different samples of size, all size of 10, but their sample mean is different, 26.2, 24.28, 25.22, right? Now, but the population mean is 25. Now we will check that which particular sample will be used for our inference purpose, right? So for that we are using the standard error. So which particular sample having the smaller standard error, that will be preferred for our inference purpose. Okay, so this standard error is a measure of sampling variability. So sampling variability, because variability, our purpose is to reduce the variability.
So Davinder, in this particular example that you are showing, the normal
Yes.
curve that you are showing. Now you
Yes,
said
yes.
that population mean is 25 and
Yes.
standard error 25.22. So you want to say that perhaps you will be banking on this particular value more than any other value?
No, ma'am, actually this 25 is our, exact value. What is the population value? And we are testing it with different samples. We are just estimating it. Like from different, we have taken 3 samples from different 3 locations, and each has 10 sample size. Which particular we will take the standard error, and on the basis of those particular standard error, we will check that which particular sample is true representative of our population. So standard error of the mean, this is the formula for standard error around the mean, S upon under root n. So this S is nothing only this sample variance. This is standard deviation. This is the S. This sample variance, square root of that is standard deviation. Standard deviation upon under root n. So this n is sample size, right? So this is a formula for the standard error. So n is sample size, n is large, we can get the good precision for the standard error. So always smaller standard deviation, standard error is preferred. Smaller standard error is preferred for our inference purpose. So here you can see that, and this is the formula for the standard error. Now we use this formula in our formula for this standard confidence interval, because in confidence interval we are using this formula: sample statistics plus minus confidence level, measure of how high sampling variability. Okay, so since sampling variability comes to the standard error, right? So now we got all the values. Now here we can see that this standard deviation depends on there is an inverse relationship between standard error and sample size, right? So as much as sample size will increase, your standard error will decrease, right? So always remember that for the confidence interval, your sample size, your confidence interval will increase if sample size will decrease. There is an inverse relationship, right? So this is the case I have mentioned, right? So this is the general formula. Suppose,
so I want you to tell us how you have calculated this 95% confidence interval of 175 was perhaps the sample mean, and how have you calculated this?
I'm just saying that.
Verify this.
Yes. So ma'am, this is the representation of the 100 observations of heights of men drawn at a random from a large population, and sample mean is found to be 175 centimeter. This is the sample mean, and standard deviation is 10 centimeter, right? So we get this particular sample values from any population, and we know that the population mean is 175. Now, can we make any statement about the population mean? Now this range, we have to find out this range, that the sample mean is 175, and so what will be the value of population mean, right? Because we have to estimate it. So either we can go for a particular point estimate, or we go for the interval estimate. So in interval estimate, we will provide the range in which the average height of the population will lie, right? So here we will find out the confidence interval for mean. This range is called the 95% confidence interval and can be an important adjuvant to a significance test, right? So now we have to find the confidence interval of mean for the whole population, right? So what is the formula for that? So what is known to us? So in this example, we have sample size because we have 100 observations. Sample mean is 175 centimeter. Standard deviation, it is already given. Now we will calculate the standard error. So what will be the value? How you calculate standard error? S upon under root n. S is your n, standard deviation upon sample size. So that will be your 1. So this standard error will be 1, right? So now we put the formula values in the formula, that is statistic. Our statistic was mean. Statistics is associated with a sample. So our sample mean is 175. Confidence factor, that is the value of 95%. So it is 1.96 because the Z value for mean at 95%, that is 1.96. And the standard error is 1, right? So the value will be 175 plus minus 1.96. So this is your range. It means the value of height of population lies in the range of 173 to 177.
Is the confidence factor always taken as 1.96?
No, ma'am, it depends upon the confidence interval. I will tell you, ma'am, in the next slide that sometimes it is taken as 90%. If you are taking the 90% confidence interval, then this 1.96 will change. Sometimes it is taken a 99%, then the value will be different. But standard value, if it is not given, then always take 95% confidence, and the value of Z is 1.96. Because this is the constant value which is from the table, and the rest will be calculated as per the question. Now, if the numerous random sample of size 100 are drawn and the 95% confidence interval is computed for each sample, the population mean will be within the computed intervals, that is 173 to 179. Now, what is the relationship between sample size and confidence interval or range of the confidence, right? So this is the mean reliable areas with 95% confidence interval from 20 samples. We have 20 samples of 100 houses in a rural area. The star indicator, the confidence interval does not contain the population mean. So this is your population mean. So this mean value is your 24.5, 24.2. This is your exact population mean. Right. So ऐसा नहीं होता है कि it is not always right that you will not get any particular value for that particular statistic or parameter in the confidence interval. If you have confidence interval lower and upper, then definitely your particular value of population will definitely lie in that particular interval. Okay, so this is the interpretation of confidence interval. We are 95% sure that the true parameter value is in the 95% confidence interval. For the confidence interval, we are proposing there is a 95% chances that the true parameter value will lie in that particular interval. Or if we repeated the experiment many times, 95% of the time, the true parameter value would be in the interval. So this is the interpretation of your confidence interval. So ma'am, this is the value, like confidence interval if you are taking, so this is value for this P is only for the analytical studies. Confidence interval 95%. We take the P in 0.05. Confidence interval if you are taking the 99%, then P value will be your 0.01. So P value is always taken for the analytical studies and confidence for the descriptive and analytical studies. So this is the formula for the general formula for calculating this confidence interval. This is standard error. This is the Z value, and P is the point of estimate. That is the sample mean, sample variance, sample standard deviation. So what the statistic value is there? You have to calculate it with the help of sample, or it is given in your question. So this is the example that 100 newborn babies, mean birth weight is 3000 and standard deviation is 400 grams. So what will be the 95% confidence interval? Okay, so X bar, that is sample mean, is your statistics plus minus the 95%. So it will be 1.96, and then standard error of mean, right? X bar will be your 3000 plus minus it, like 1.96 into standard error will be your 400 upon square root of 100. So after calculating, you will get 3000 minus 80, 3000 plus 80. So your result will be, range will be 2920, 3080. So this in particular range, this will lie. Because what we are calculating here is only the sample, but we need estimate for the population. So I will not go into that because these are different, formula for mean. Sometimes it will come for in the form of proportion, because we have to find out the difference between the proportion. Sometimes we have to find out the difference between two means. There are two groups. One is smokers, another is non-smokers, and we have to find out is there is a significant difference between their systolic blood pressure or not. So the method will be same. You have to calculate the sample mean, sample proportion, sample deviation. So the method will be same for the confidence interval for all kind. Okay, so the other for commonly supplied confidence interval are like relative risk, odd ratio, sensitivity, specificity, likelihood ratio, relative risk, number needed to treat. So they all comes under the confidence interval. We can calculate the confidence interval for in these kind of sampling statistic. So what is the characteristics of confidence interval? So because the precision of estimate is indicated by the width of the confidence interval, right? So width means if the range is 20 to 25, so width will be like your 5. Like what is the difference between upper limit and lower limit? So wider the interval, the less precision. Okay, we are saying that the height will lie from 150 to 160. Okay, this is the one case, and another is case there is a 155 to 158. So the wider the interval, less precision. Now the width of confidence interval depends on sample size.
Dr. you are frozen. Hello. Dr. Dharmendra, can you hear us?
I don't think he can, but Dr. Bindu, while he comes back, would you like to discuss what Dr. Dharmendra has spoken of so far? We can't hear you either, Dr. Bindu.
I think he's made it quite clear how confidence interval can be calculated. He's shown us how to go about it. That is very clear, especially if mean is given and how standard error, if standard deviation is given, standard error can be calculated, and using the standard error one can calculate the confidence interval. But to say it in for us in our from a clinical point of view, he has to I think tell us the difference where exactly, whether if where what is the role of effect. And if there are two readings, say it is very clear if the sample size is too big, then perhaps the confidence interval is smaller as compared to if the sample size is small. But how does it? It is in clinical terms. He's I think about to tell us how to go about it.
Okay, ma'am. So actually, this effect size. I'm audible.
You are audible.
Yes, yes. So, ma'am, effect size generally tells us about the magnitude of the difference. Like if two groups are different, there is a significant difference between two groups, like systolic blood pressure in the smoking group and non-smoker group. So this effect size will tell you, because in like confidence interval, they just tell what is this particular magnitude. In effect size, tell us you what is the exact difference, right? So sometimes it is absolute effect size, and sometimes it is a calculated effect size, because this effect size tells us the magnitude. What is the magnitude of particular difference?
Okay.
So sometimes, like, we are giving the sleeping drug to the patients. Okay, so before giving the drug and after giving the drug, we will measure the number of sleeping hours. So here we can find out what is the difference between this particular sleeping hours of that particular patient, whether drug is effective or not. So such kind of experiments or such kind of treatment, we can find out the difference, exact difference. What is the absolute difference between the number of sleeping hours? So this is called absolute effect size. So this effect size tells us about the magnitude of particular difference between different groups, different interventions. Like we are giving the different interventions to different groups. So we will check whether this intervention is effective or not.
So absolute effect size or point estimate are parameters that you can directly estimate from your observed values, right?
Yes, yes.
And standard error is something that you infer. It's not something that you directly calculate. It's not something that's there. What you are trying to say through standard error is that if I conducted my experiment several number of times, where will this point estimate shift? It may not be the same again. So for instance, if you were looking at the results of an intervention for, let's say you were doing something with embryo glue, and you wanted to see if this particular embryo glue, putting the embryos for about 10 minutes in a certain kind of substance in your media, is going to change your live birth rate vis-a-vis standard practice, and you enroll something like 100 patients in that trial, and 100 who received standard care, and you found that in the standard care, your positive beta HCG rate was 40, whereas in the other, it was about 45. The difference in proportion is 5%, which is known as absolute difference in effect, or the effect size here is 5%. But the question that you're trying to tell the world, that these 100 women that you enrolled are not the entire, 10 million women of the world who might be going through IVF. So what you are saying is that even though my sample is small, which is 100, if you had to take another 100 from another set, maybe in a different city or, in a different country or in a different time point, would your estimate still remain 5% difference? So the answer is no. Clearly, it will vary because, there are different kinds of populations. So it will vary from 5, maybe 6 or 7 or 8 or maybe 4%. Through confidence interval, what you are saying is that if it varies, it will not vary more than this or less than this. So when I say 5% with a confidence interval of 3 to 5, of 3 to 7, what I'm saying is that if I repeated my experiments 200, 100 or 5,000 times over with 100 people, it will vary between 3 and 7% alone. It won't go ahead.
Yes.
something which is something that you derive. It's that, which is why it comes in the purview of inferential statistics. It's not something that your observations will tell you. Your observations will just give you that 5% difference. But
Yes.
every time you present your results, you have to give a confidence interval that if this was to be repeated 2,000 times or 1,00,000 times over, the results should fall within this range, right? Now within that, you have to estimate if this result is statistically significant. And this is where the concept of probability comes in. Probability is it's the probability, or the result p-value is the probability of finding the same value. So let's say 5%, whether it is going to lie within what would have been the truth. So there is a truth wherein you know that this is not going to work. You know that your embryo glue is not really working, that a 5% difference isn't, it's just happens by chance, that ideally the difference should have been 0, which is known as the null hypothesis. So now you're trying to estimate that what is the chance that this difference is just a random chance, that it is lying, and how many times would it recur if I did it? So when you put it at 5% or 0.05, and your results are coming as less than 0.05, you will say that this is
Less than or equal to.
Yeah, this is happening, maybe only 3% of the times because of chance. And when you are saying that if it's less than 0.05, let's say the value is actually, probability value is 0.03, you say that this difference, because is insignificant only in 3% of the cases, that it will be closer to the null hypothesis only in 3% of the cases. That is what probability is. Probability is the actual probability of finding that your result is actually where it is, and it is going to be more extreme than that. So if it is going to be more extreme, it is a rarer outcome, you say that this difference is actually true. 5% difference is actually true. So I think we'll administer the poll at this point, unless there are any more questions. There was one question on...
So, ma'am, I want to, one thing. Because sometimes there is a difference between level of significance and p-value.
Yeah.
Right. So generally we say that if the p-value is less than or equal to alpha, that is level of significance, we generally go for, reject the null hypothesis.
Yeah.
Otherwise we do not reject.
Yeah.
But what we can say, because in social science and in other research, we fix our level of significance prior to conducting the experiment or any this one study. Okay, we generally say that we are fixing our alpha, that is 5%. Okay, so but after conducting that this research, we will verify whether our findings are supporting particular that null hypothesis or not. So for that we use the p-value.
Yeah.
Right.
Yeah.
So this p-value is nothing, only the probability of accepting the null hypothesis under the assumption that it is true.
Correct.
We are saying that it is true. We are assuming that null hypothesis is true, that there is no significant difference. So now we will check that how is statistically, what are the evidence for accepting this particular statement that there is no significant difference. If it is less than 0.05 or 0.01, it is not always 0.05. Sometimes it is 0.01 also. Right? Because if you are, it depends upon the significance level. If you are taking the 95% at the 5% level, then 0.05 will be there. If you are taking the 90%, yes.
Yeah, that's said by the researcher.
But I found there's a lot of controversy on this p-value, because p-value was started to find out to check what we have done. How much data is supporting that?
Right.
Okay, but it depends upon so many factors, like it depends upon the sample size, it depends upon the methodology, study design, it depends upon the variability among the samples, right?
Yeah.
So you cannot, on the basis of p-value, you cannot directly say that our hypothesis is rejected or do not reject it.
Yeah.
Okay, because you are the best person. So that's why there is a concept of clinical difference. Not clinically significant difference, not only the statistically significant.
Correct.
Okay, there are so many things like 0.05 or 0.01 or 0.001. उससे आप क्या हुआ थ्रेशोल्ड से you can say that there is no significant difference. But उस 0.01 से the person will lose their life.
Correct.
So you are the people who will directly say, because this clinically significant is very important, also important. So
Yeah.
that's why there is a good papers I have found. I will forward to all of you. There is a common debate on the p-value and the clinically significant difference.
Correct.
So American Statistical Association, they clearly mention that p-value is not a criteria for decision making.
Right.
So you just identify both things.
But we do take it as a statistical significance less than 0.05 as the p-value, in spite of all our thesis or whatever research we do. So that is important to differentiate where exactly, whether even if the result is not less than 0.05, it doesn't mean it can be dismissed.
Yes, ma'am. It will generally said that, and we are always say that we are rejecting the null hypothesis or do not reject null hypothesis. We cannot say that we are accepting the null hypothesis. Generally, in SENA, like in court cases, also you are in the lack of evidence, you are not found guilty. But we are not saying that you are innocent. So in the same manner, in statistics also, since data is not supporting the evidences to reject the null hypothesis or do not rejecting, but we are not saying that null hypothesis is true.
That's why we say we need more randomized controlled trials to be able to
Yes, and the p-value is only the part of evidence. It is not the proof.
Correct.
So I will send those two research articles. They are very good.
Thank you, Dr. Dharmendra, for that. I think on that note, we'll administer the poll on probability interpreting p-values. Shivam, can we have the quiz, please? Okay, here it is. And I hope you'll be able to respond to these. It's 5 questions, 1 minute each question, and stop the poll at 5 minutes.
We urge all the delegates to please fill the answer the polls. It was a very interesting talk, Dr. Dharmender and Bindu ma'am. It was a very explicit talk talking about p-value confidence interval. And yes, you have put our thinking caps on that p-value being less than 0.05 doesn't mean that the difference has to be there. So I think it was a very good and well explained talk.
Thank you, ma'am. Thank you all.
In the meanwhile, would you like to tell us, Dr. Dharmendra, about how to calculate the standard error for odds ratios? I know, I mean, it's a mathematical formula, but just the principles that most standard errors have sample size in the denominator, and they are root of the thing. So that larger the sample size, smaller will be the standard error. And that's something, if they can understand the audience, that it is, so odds ratio, would you like to tell us the formula for that, if you have it on screen or otherwise?
No, ma'am, actually currently we don't have, but I think we can calculate the odd ratio like this standard error for the odds ratio as well, just like sample mean. So like sample mean we have and sample is like standard deviation sigma by or s upon under root n.
Yeah.
So we can find out the difference between
the square root of group sizes. So
yes.
odds ratio is basically the odds of event happening in the exposed upon odds
Not
of event
happening.
happening in the unexposed. So you have 4 groups. You have one in the exposed group having the outcome, one in the exposed group not having the outcome. So let's say we call them A and B. You would have a group in the subgroup within the unexposed that will have the outcome, and a subgroup within the unexposed that will not have the outcome. Let's call them C and D. Then the standard error would be 1 upon root of A plus B plus C plus D. So it's basically a square root of root A plus root B plus root C plus root D. So basically what you need to remember is that all point estimates have different formula for standard errors. You really need to know them. It goes to the statistician for all kinds of calculation. But the point you remember is that larger the sample size, smaller will be your sample error, the standard error, and closer will your point estimate be to the truth. So if you want to really conduct good experiments first, which is why the stress on sample size being right, and it is based on so many other parameters. We've had a talk on this in the past. Hopefully we can do
It's
that.
5 minutes now. Should we share the results?
Yes, please.
Yeah. Here it is.
Right. Okay, that's 40% participated. Dr. Garima, would you like to take this? Okay. So question 1, we got the C was the right answer, and that's 83% got it right. That's well done. I think Dr. Dharmendra managed to get that across. And in question 2, the answer was the probability of what is p-value. The p-value in hypothesis testing represents which of the following. Please select the best answer of those predicted. And the correct answer as per this quiz was the probability of observing results as extreme or more extreme than currently observed, given that the null hypothesis is true. Dr. Dharmendra, would you agree with this answer, or is it something else? Because no one got this right.
No, actually, generally we say that in p-value, we generally say that I have told you that we are, it is the probability of accepting the null hypothesis under the assumption that it is true.
Which one would you mark up within A, B, C, and D?
This one, D.
Correct. So
Because-
D was the correct answer, and unfortunately, no one got it correct. But let's have another class on this, explaining it with
Yeah,
examples.
because I think I have covered this confidence more, given the more time on this confidence interval, but I will try to do the p-value as well.
Most people thought it was the probability that the observed results are statistically significant, given that the null hypothesis is true. Okay, so we need to just clarify this again. A result is called statistically significant whenever, okay, 100% got it correct. Excellent.
Because everyone is running behind that.
Very interesting. And which of the following practices constitute p hacking, although it wasn't spoken of, but 83% got it correct. Analyze many outcomes, but report only those where p is less than 0.05. Analyze subsets and compare with each other till at least one comparison shows p less than 0.05.
Yeah, so this data hacking is like this p hacking is just like a data manipulation.
Yes.
If it
Do
is
we
not,
have
it is
still-
not significant, but you are making it significant.
Correct, correct. And the last one was a bit of a trap, I think. But what this question was asking you was ADPKD, which is adult onset polycystic kidney disease, is a genetic disease that shows an autosomal dominant inheritance pattern. And you have a couple who's undergoing PGTM for ADPKD with affected husband. So one person is affected, the other is unaffected, and the inheritance pattern is 50% chance of transmission. Now they have 4 blastocysts, which means, and the question that is being asked is, what is the probability that at least one of the 4 blastocyst biopsy turns out disease-free? Now, this is basically a question that we face every day, and because we have to respond to questions on how many blastocysts should be made in order to give us a disease-free blastocyst that will give us a pregnancy. So normally when we look at blastocysts, we are looking at an implantation rate per blastocyst of 50%. We want to make 2 disease-free blastocysts, right? So if, let's say, they have 4 blastocysts, the question being asked is how many of them, or what is the probability that at least one of the 4 blastocyst biopsy turns out disease-free? Now, this was a probability question. Maybe we'll have, so at least this is giving me ideas on what to discuss next. Everyone got it wrong because the answer here is 93.75%. Dr. Dharmendra, would you agree? This is basically a probability question. So what we do here is we assume the reverse. We assume that one of the blastocysts, every blastocyst is diseased. We try and calculate what is the probability of having every every blastocyst that is diseased. So the question here being asked is, what is the probability that at least one of them is not diseased? Would be 1 minus all diseased, right? So, and the answer is 1/2 raised to the power 4, 1 by 16. And that comes to 6.25%. So it's 1 minus 6.25, which is 93.75%. But let us just come to that in another class. So, so thank you. Thank you so much for this class. And we are going to try and answer more clinical oriented questions in our next module. And we shall be informing you about when we conduct them, and we'll do more clinical practice, maybe pick up papers and try and interpret different statistical sort of paragraphs that are mentioned within them. We'll try and pick up landmark papers on reproductive medicine and try and interpret the statistics that has been done within that. So thank you so much, Dr. Dharmendra, for this. Thank you so much, Dr. Bindu ma'am, for moderating this. And thank you so much, Garima, for conducting the program. Also to the participants who hung around till the end, thank you for being there. And the backend team, we really like to thank you for supporting us in every way possible.
Thank you so much, Dr. Uma.
Yeah, thank you. Thank you so much.
Hi, Dr. Garima. Thank you, Dr.
Thank you, ma'am. Thank you. Thank you, Dr. Mehndra. And next module, if you have any topics,
you.
if the delegates want to suggest any topics, please share with us for your feedback. We'll plan somewhere in September or October. We'll get back with the date. Any feedbacks from the current would also be appreciated. Thank you.
Thank you all.
Thank you.